So thank you everybody for listening in. Sorry to be late. I usually start with a quick ECG, which we maybe don't need to since I think pretty much everybody's in already. But since I've prepared one, let's go through it. So can anybody very quickly tell me what this ECG shows? Okay. So it's the right theme for our presentation today. It shows electrical alternans. So you have various heights of the QRS complexes. And that's, of course, because our electrically active heart is inside a torso. And if you have small QRS complexes, it could be that you've got a lot of insulation in a big torso, or a COPD, or a pericardial effusion. And think pericardial effusion. Imagine a goldfish bowl with the heart inside it, waggling around. Sometimes the heart's closer to or further away from the electrodes. And that's why you get the electrical alternans. So with that behind us, let's move on and talk about how we actually deal with this problem. So pericardiocentesis, how do we fix it? I think pericardiocentesis is one of the most challenging procedures because it doesn't come around very often and because it can be extremely tense when it comes to doing a pericardiocentesis. It's very much an emergency type procedure at times. Hopefully you get the opportunity to do it when it's a bit more relaxed, but it's always difficult as a registrar to be involved when there's a major emergency. And I think this presentation, I'm going to try and distill all the knowledge that I've gained over the years and how to do pericardiocentesis. If there's something I've missed out, then I'd be grateful for you to add to it and maybe able to add to my knowledge. And hopefully you'll be able to use this as a reference to think about pericardiocentesis in the future, because if you mentally rehearse it, when it comes to it, it will be easier. Can everybody hear me okay? Good. I'll just move your, yes, I can see you as well as I can. I have a few screens, so it's nice that I can all see you all in the background there. Great, so moving on with the pericardiocentesis. The outline of this, I'm not going to talk about the theory of what we're doing at all, and why we do what the indications for pericardiocentesis are, etc. I'm really going to concentrate on the procedure itself. So I'm going to talk about the complications briefly, and I'm going to spend a lot more time talking about. Somebody needs to mute themselves, I think. So I'm going to spend a lot more time talking about the echo preparation, the anatomy, why we do what we do, go into the technique and the specifics of it. How do we work out if the needle's where it's supposed to be? That's a really key part of the procedure. And then a little bit about aftercare and special circumstances and troubleshooting. Has everybody seen Pulp Fiction? So this is not what your pericardiocentesis is supposed to look like. If it looks like this, then something has gone deeply wrong. Complications. I would tend to quote this list to patients, and that's what I'll be expecting to hear from you on Thursday. So less than 2% risk from the procedure, but those risks can be very serious, including myocardial puncture or laceration. They can include vascular injury. That would be of the coronary arteries, particularly the left anterior descending artery is at risk depending upon our approach. There's a risk to the intercostal arteries, the internal mammary artery, or less likely an intra-abdominal artery. The risk is of pneumothorax. Obviously, from any approach, we could have to go through the lung. And if we're doing bubble contrast, there is a risk of an air embolism. There's a risk of arrhythmia caused by inserting the wire into the ventricle, and there's a risk of damage to any of the intra-abdominal organs. Hopefully the liver is the big one there, but I would just say intra-abdominal organ. And there's a risk that we fail to succeed with our pericardiocentesis, either because the leak doesn't stop or because we can't get the drain in. When we have a case of pericardial tamponade, or pericardial effusion forming, you have this balance between a gradual accumulation versus a rapid accumulation with how fast the pressure goes up, because the pericardium is stretchy and it's very variable how stretchy it is. I had a 20-year-old who had a 3 centimeter pericardial effusion that developed over the course of a month. So it can stretch relatively quickly, particularly perhaps in young patients. But if you very rapidly accumulate the fluid, you will get tamponade with about a 1 centimeter pericardial effusion. Whereas if it gradually accumulates, it can take a lot longer before you actually develop the tamponade physiology, and it tends to be less acute in those situations and much easier for you to drain. So what you're hoping for is a gradual accumulation to the point that it needs to be drained either for diagnostic or therapeutic reasons. When you're doing a pericardiocentesis, it's important to prepare the patient. It's important to prepare yourself and the patient carefully for the procedure. And usually it's an urgent situation, but it's not generally an emergency situation when you are involved with it. You will have to at some point deal with the true emergency, usually procedural complication where the patient is in tamponade and needs to be drained immediately, and that's a really tough situation. But most of the time when you're involved, it's an urgent rather than a true emergency, and therefore you've got half an hour to read some of the theory behind it, to just mentally go over what you're going to do. So what bits of patient preparation do we want? Well, first, get the patient comfortable and you comfortable. And a wedge behind the patient can be very helpful for getting the patient more upright, and for changing the way the fluid is pooling in the pericardium, which can make it much easier for the pericardiocentesis window. So try a wedge. You might want to put a pillow under one side to slightly roll them left or right, not too far. It's obviously a narrow table, but whatever you can do to try and make the pericardial fluid pool better. We can sedate the patient, but just while I would absolutely say patient comfort is really important, and do your utmost to achieve patient comfort. Somebody's got their mic off. It's rather noisy. Somebody's rustling. I think I can hear that if nobody else can. So while it's really important to make patients comfortable, just bear in mind, if they are truly in tamponade, if you suddenly relax them with midazolam and turn off the adrenaline production that's keeping their blood pressure up, that's keeping them conscious and perfused, then they can suddenly drop off fast. So if you've got somebody who's acutely distressed, they may well need to be sedated. But if you've got somebody who's truly got tamponade in front of you, then to rush in with sedation does risk making the patient deteriorate and drop their blood pressure. Before you get the patient to the lab, if at all possible, do the echo. Now, I would almost mandate it, but if you've got a true emergency and you know that you've got to drain the effusion, you want to just get them to the lab as quickly as possible, that might be a reasonable position to take. Although if it's really that much of an emergency, maybe they need to be done on the ward. But if you've not echoed them and echoed them yourself, as opposed to looked at the echo done by the echo technicians, then you've not had the opportunity to do it without any heat on you from everybody else watching what you're doing, from everybody sort of tapping their feet and saying, what's taking so long? You've got, as much time generally as you want to work out your angle of approach, to think about all the things that you need to think about with echo in order to do a good pericardiocentesis. And I'll come on to that and into what that is in a minute, but I would really emphasize the benefits to you of spending a lot of time doing the echo yourself beforehand. And if you don't do an echo at all, you just rush them straight to the lab, then sometimes they get there and there's no good window, and we end up saying we can't do the pericardiocentesis, and that's an avoidable complication. So do the echo first and think, is it a viable procedure? And if you're not sure, get somebody else to check it. So what do we think about with the echocardiogram? There are lots of different and all very important aspects of this. We want to achieve the best separation that we can between the pericardium and the myocardium. So we want to be able to stick our needle in without hitting the myocardium. We want the best distance that we can get between the skin and the pericardium. So we don't want to have to put the needle in 20 centimeters in order to get to the heart. So this and this are two key parameters, and you need to have it in your mind what those distances are and to remember them when you're doing the case. If you need to insert the needle 10 centimeters before you're going to hit the heart, then you need to know that so that you know that you're inserting 10 centimeters before you're expecting anything. If you then have a 1 centimeter gap between the pericardium and the myocardium, then it's going to be very hard for you to successfully get the needle into the pericardial space without touching the heart. So you need really ideally 2 centimeters, a minimum of 1 centimeter, and these two factors will affect the difficulty of the procedure considerably. If you're just joining us, we are recording this and I will be posting it online for you to all to watch ahead of Thursday. The other key thing you're looking at with your echo is your angle of approach. Exactly what angle is your needle going to take? And imagine the echo probe is your needle. You're not aiming to get the most beautiful of pictures. You're aiming to replicate the track the needle is going to take with your echo so that you can see if it's going to go through the liver. You can see exactly how far you're going to have to go. As I said before, get the patient to different positions. It might be that the best echo separation is achieved lying flat, but more commonly you want them on a wedge, or you might want them leaning slightly left or right. It can make a really very big difference to this, and take your time to get the patient in the right position. We've got these great inflatable wedges now in the lab that you can really vary the position of the patient very well with. And as you're doing the echo, be thinking about where the liver is, be thinking what your risks of the procedure are, and weigh the 3 different main approaches, which I'll be coming to in just a moment, but weigh which of them gives you the best chance of success and the least risk. And within all of that, think about your margin for error. It's no good at all you taking on a procedure that's going to go beautifully, providing you get the needle in to, you've got barely any error margin at all. Your chances of managing to follow that precise track are too low. So think about your margin for error when you're weighing up all these different considerations. So a little bit more about what do I mean there, a little bit more about what are we actually looking at practically. If we see these 2 subcostal views, you can imagine this is systole, and we've got a really good echo separation. You can imagine this is diastole in the same patient. You've got some right ventricular free wall collapse, so that's an echo parameter for tamponade. Of course, tamponade is a clinical diagnosis, not an echo diagnosis, so it's suggestive, it's not confirmatory. But you can see that we've got a good 2 centimeters, probably more like 3 centimeters echo separation in systole, but it's much less in diastole. But it's still a centimeter, although perhaps not if we go straight down, straight at it here. We're perhaps wanting to go over here. And you've got the liver in the way in both of these shots. So you can transect the liver if you have to, but it's not advisable if there is a way around it. And bear in mind that if it looks like this in systole, the heart is moving. And so it may be constantly thrusting itself against the needle that you've just put in there and repeatedly puncturing holes in it. So this amount of separation would not be enough to do a pericardiocentesis. This is obviously a live, a real cine of pericardial effusion with the expected tamponade. This is the liver here. So we're trying to get in here, but we do not want to go through the liver. And the problem with all the views that I've been able to get online, I wish somebody needs to switch off their microphone, please. The problem with all of the views that I've been able to get online is that they are showing pretty pictures of the heart rather than the track that your needle is going to follow. And you don't really care about beauty. We don't need to be able to see the wonderful endocardial definition, but what we do want to see is where the border of the heart is that we're approaching and where the border of the pericardial fluid is and whether or not there is liver. So I want you to take a much steeper angle than you might do normally. It won't give you a 4-chamber view of the heart, but it will show you that there is a way through subcostally that doesn't mean that you have to transect the liver. This is another example of how there would be a really big liver in the way with this view here, such that this really would not be a good idea. You can always see the blood vessels that you might be puncturing on your way through to the pericardium. So this would be an example of one that isn't drainable and would be extremely deep. I'll come back to the actual anatomy and the procedure done subcostally in a minute. If we go on to the apical echoes, can you see in this example that there's nice big pericardial effusion over here, which we could get at with our needle? You could almost get it going straight, but the echo separation would be much better if you go in at a bit of an angle. Sometimes though, or often in fact, the very apex of the heart, there isn't a lot of fluid. And here you've got no choice but to go in at an angle relative to the usual apical view. And this is where it's really important to get the probe to pretend to be your needle and to rotate things round and to accept that as you've rotated things round slightly, the view is not going to be as good. But what you do get from doing that is you can know the exact angle that your needle is going to take. You're not looking at the echo probe and trying to work out what a few degrees left or right of that is, or up or down from that is. Your echo is the angle that your needle needs to be at. And that is a very valuable thing when you're doing the actual pericardiocentesis. And what I said earlier about the error margin, think of this, we could successfully drain this effusion if we get it in any of these tracks, but that angle, we've only got about 10-15 degrees of error margin there. So we do need to be fairly precise if we are going to successfully drain this effusion, and that's doable, but it's only doable if you're very, very carefully checking and rechecking and concentrating on the echo tract. And I would urge you to, well, I'd insist that you have the echo probe sheathed so that you can do it in a sterile manner with part of as part of your procedure. And the very last thing you do before inserting the needle is to re-echo to work out your angle again of your approach. The echo is not just there to tell you that you can approach it subcostally or apically. The echo is there to tell you exactly the angle and direction and depth that you need to be taking with your needle. And here you can see that there's not that much error margin in terms of the angle, but there would be a lot of margin for error in terms of the depth that we go in, particularly if we're on the outside of the error margin for the angle. If we're going parasternally, there's usually not a lot of distance between the chest wall and the pericardial space. So it's nice that it's not very deep, but the problem is it's also usually there is not a lot of echo separation. So your precision when you're trying to go parasternally in terms of the depth and controlling the depth has to be very great. And that is something that you need to really be concerned about. I'll come on to the why in just a moment. But parasternally, the echo separation here is often not more than a centimetre, unless it's a really huge pericardial effusion or if it's unusually distributed. So I would advise against a parasternal approach where there are other options. Here, the depth, there's no margin for error, but the angle, well, we're going perpendicular. It's easy to go perpendicular, but you can see how, providing you avoid the intercostal vessels, you could go in whatever angle you like and you'd still get into the effusion. So where do we approach the pericardiocentesis if we're doing an apical or a parasternal or a subcostal approach? Well, no matter where you look, it's the same diagram. I got this off Up to Date, but you could look in any textbook you like. It will be exactly the same diagram, which was why I've called this the wisdom of ages. This is what people have said and everybody else has just copied them. And I would want to adapt this slightly because we don't just have to go here in the fifth intercostal space. We could go in any of these intercostal spaces. And really, so long as we avoid this region here within 6 centimeters of the sternal border, we can go wherever we like. The caveat being that if you can't see the heart, then there's lung there, so you'll cause a pneumothorax. So what you're trying to do is find where your best apical view of the heart is and the one that gives you access to the pericardial effusion, but you've got quite a lot of flexibility in where that is, so long as you're at least 6 centimeters round. And why not be a bit further round, given that you've got all this opportunity to go more laterally. When it comes to doing a parasternal, it's the same in every single diagram that you see, but this needs to be within 1 centimeter of the sternum. You want this to be as close to the sternal border as you can get. This is probably 2 centimeters away, so I would say is too far away. So as close as you can get to avoid the internal mammary artery. And if you're going subcostally, you've obviously got all the options around here, avoiding the xiphoid process. So if we look at the anatomy to think why we're choosing those approaches, you can see here the bones and the arteries, and this is the internal mammary artery running down. Depending upon the diagram that you look at, it'll be closer or further from the sternum. This is a relatively far from the sternum image. You need to be as close to the sternal border as you can be in order to avoid the internal mammary artery. So if you're going parasternally, within 1 centimeter, but if you can go 0.5 centimeter away from it, then that's good. If you're going apically, then you want to be at least 5 centimeters, at least 6 centimeters lateral to the sternal border. And that's in order to be safe, given the variation in the course of the internal mammary artery. Now, there are obviously other blood vessels shown on this, but these don't follow a set path, so we don't have specific anatomical landmarks to try and avoid these. The heart's obviously, and the lungs are within the rib cage, so if you think about how the heart and the rib cage line up, and then we take away the rib cage, I'll just do that again. Can you see how close to the sternal border the internal mammary artery is? Sorry, the left anterior descending artery is. So going parasternally, you do risk hitting the LAD in its proximal or mid-course, where you will cause all sorts of harm. So parasternally is certainly an option, but it's not a preferred option unless you weigh up the risks of other approaches and come back to it as the best option for the patient. Don't go for it as your first choice. I'm not saying don't attempt another approach first, but I am saying think about the other approaches first. Any questions so far? I'll obviously take questions at the end. I'm kind of not making this interactive really in the interests of I've got a lot that I want to get through and tell you about. So the technique itself, as I've said over and over again, you need to mentally note from the echo the exact angle that you're going to approach it at, and think in 3 dimensions with your angle. Think about the distance to the fluid and the depth of the fluid and the error margin that you have. And also remember that particularly if you're going subcostally, that you're pressing the echo probe on the abdomen, and that will have quite a significant effect on the depth. So imagine you are pressing on somebody's abdomen, you're pressing underneath the ribs, and you're really going to affect the angle that the needle is going in at. If you and that 2 centimeters can make a big difference. If you imagine somebody doing a pericardiocentesis, you don't squash the skin with the needle. So you do the pericardiocentesis here, you're going to follow a different track. When you're doing a pericardiocentesis, infuse the local anesthetic. Make sure you generously infuse the skin. That's going to be the most sensitive area. And I generally infuse to the depth of the green needle. I then have a bit of local anesthetic attached to the end of my pericardiocentesis needle and infuse more if I need it. But providing you've infused to the depth of the green needle, you'd very rarely need to go any further. Make a little nick in the skin. You can go through it with the needle and make the nick afterwards, but you will find it hard to get through skin with a pericardiocentesis needle. It's relatively blunt. If you're trying to do that, the trocar will allow you to do that. That's what the obturator will allow you to do that. Otherwise, and I more normally would do a little nick in the skin to just cleanly get through the skin. Otherwise, it's quite hard to control the needle when it's all outside the patient and you've not anchored at one end of it. And you need to be very controlled at all times. So a little nick in the skin can make life easier. And I'm going to talk about the 2-handed technique for doing it in more detail in just a second. So just before we get on to that, think about the needle that you're using. And remember that a needle is like a knife. The end of a needle has a cutting edge that you can use to lacerate the liver or cut your fingers on it or cut through sutures with it if you want. So it's a sharp tip. It's a little knife at the end. And when you're putting the needle in, there is what we call the break-in depth, which means you have to insert the needle sufficiently far that you can actually put your wire through the bevel in it. And that break-in depth is very different depending upon standard bevels versus short bevels. Now, I know some of you use a Kimmel needle to do pericardiocentesis, and that's something which I would frown upon. Can you see this is a Kimmel needle on the left? This is the pericardiocentesis needle on the right. It's a slightly smaller size, French size, but the crucial thing is that it's a much shorter bevel. And that means that the cutting bit here is just about 1 millimeter long compared to about 2 or 3 millimeters long on the Kimmel needle. So your risk of damaging, of lacerating something is lower because it's got a shorter knife on it. And the break-in depth is also considerably shorter. So you don't have to stick it as far into the pericardial sac to advance your wire if you're using the pericardiocentesis needle. The pericardiocentesis needle comes with the obturator, and that is really important if you're trying to get through a tough fibrous structure. And sometimes the pericardial sac will be heavily fibrosed, particularly if the pericardial fusion has been there a long time, and you simply won't be able to push the standard pericardiocentesis needle into it. You'll probably be able to get the Kimmel needle into it because it's sharper. and it's bigger and it's a more standard shape. But if you put the obturator down the pericardiocentesis needle, you will then be able to go through it. You'll be able to go through the skin or through the pericardial sac. So if you're struggling with resistance and you know you're not pressing against bone, that's what you need to deal with the problem. How do you change the track of the needle? Sounds extremely obvious, doesn't it? But I think it is worth just thinking about it for a moment. The first thing I would say is don't move the syringe. You know, the moving the syringe will not change the track of the needle. It will just change the position of the syringe. And if you're not sure about this, grab yourselves a pen, a biro, and grip one end of it. Grip the last 2 centimeters of one end of it firmly in your left hand, and then try and change the track of that bit you're gripping firmly by waggling the other side of the pen up and down. And what you see is you just end up bending the pen. You don't end up moving the tip of the needle. So don't try and just move the syringe in order to change the track of the needle, because it'll look like you've changed the track. Remember, the bit inside has disappeared, so you don't know what it's doing. But you'll feel, because you've moved the syringe, that you've changed the track, but you won't have done. Instead, press on the middle of the needle to make it curve. And don't try and change the track if the needle is too far in. Once it's gone beyond about 3 centimeters, you're not materially going to alter the track. And remember, it's a little knife that you're waggling around trying to change the track. So if you are managing to move it, it's potentially damaging things. So I would really try and settle on my track within a centimeter of the body surface, and then stick that from then onwards. If somebody's really overweight and you're trying to change the track, having got under the rib cage, then that's a slightly different matter, but as shallow as possible in all cases. So just think about our needle in the tissue. And what I'm saying is, if you try and move the syringe, you're going to bend the needle here. You're going to bend it outside of the patient rather than inside of the patient, just as if you're gripping that biro and trying to change the angle. So you won't change the position the needle is in to any great extent. What you want to do is press on the middle of the needle, and actually the syringe will come up when the needle track is more shallow, because by making a curve in the needle, not trying to actually physically bend the needle, it flexes. You're trying to stick within its ability to flex, particularly on Thursday. I don't want everybody bending the needle and ruining it for everyone else. So just flex it, not as much as I've shown in this. I've exaggerated it in order to make a point, but in order to change the angle, you're trying to flex it in the middle rather than trying to do it from the syringe, and you're trying to do it with the needle partially withdrawn. And always use a two-handed technique when doing a pericardiocentesis. Good. So let's just come back to this view, and I've obviously put this in that I've got it off the internet as somebody showing you how to do a pericardiocentesis. And I would say that this is wrong on 3 counts. I wonder if you can spot the 3 counts that this is wrong on. The first one is that this hand is doing nothing of any value whatsoever. This is a crocodile clip. This doesn't need to be held. Why is this hand over here? I guess this person is trying to demonstrate what they've done and they think their hand's in the way of you seeing what they've done. But that hand stays on the patient from the start of the needle insertion until the needle is out and you've got a wire in the pericardium. It doesn't move. That hand is located, fixed there with the sole purpose of controlling the needle. So they should never remove their hand like this. Another thing is that the needle's in rather a long way. We can see from the obturator, this is a 20 centimeter pericardiocentesis needle. It's gone in about 15 centimeters. Wherever has it gone to? That doesn't look right to me. And then the final thing that they've done wrong is look at this angle. we're supposed to be at a 30-degree angle. This is more like a 45-degree angle. So 15 centimeters of 45-degree angle, I'm very puzzled by this procedure. Maybe it's not even a pericardiocentesis, but they've obviously assessing the ECG. So this isn't what I want you to do. On the other hand, this is much more like what I want you to do, although bear in mind that this isn't exactly how you want to approach the mannequin. Firstly, because this probably wouldn't go in where it needs to go. I'm just demonstrating. I'm not trying to give you the answers here. You'll need to palpate to work out where it needs to go. But I've got the little crocodile clip on measuring my ECG. That's at the hilt, but on the metal, not on the plastic. It's got to obviously be on the metal. And I'm holding the pericardiocentesis needle in my left hand and the syringe in my right hand. The angle, you probably want to start off at about a 45-degree angle to just get through the skin, get below the rib. But then you want to go down to a 30-degree angle. And a 30-degree angle is lower than you might think. This is probably a 40-degree angle here. You want to be lower than that. And this left hand, it rests knuckles down on the patient. If you stand up and put your hand on the desk, feel how it's going to be comfortable. And that the fingers can move, but the knuckles and the hand stays where it's put, and it does not move for the remains of the procedure. This left hand defines an angle of approach. It helps control the pressure and keep it steady. It helps us do everything in a controlled manner. If you try and do things with your right hand, everything will wag around in an uncontrollable way. This left hand is what does all the work of controlling where it goes. And because we're resting on the patient, we can do so in a very steady manner. Remember, this needle is 20 centimeters long. So when you've put 10 centimeters of it into the patient, you can suddenly think, my goodness, how long was that needle in the first place? So remember, it's 20 centimeters long. And I find a useful way of helping me to remember things and know what I'm doing is to hold the needle 5 centimeters or however many centimeters from the end that is the depth to the pericardium. Now, obviously, my fingers are going to have to move at some point, but if I note where they are when I move them, it can really help me know how far I've advanced the needle and how far I need to advance the needle. Very often you will need to advance the needle further than you think you do, and I'll come on more to that in just a moment. Your right hand is mainly aspirating on the syringe. It can also apply a little bit of gentle controlled pressure, but its main job is to aspirate on the syringe, and the pressure can come from your left hand, and the pressure has to be controlled by your left hand. And at no point are you pushing hard or in an uncontrolled way. What you want is, if you're having to press hard, you're pressing hard with your left hand, and you can only press about a centimeter before you can't keep that pressure on with your left hand. So it's a much safer way of doing it rather than pressing with your right hand. You could push all 20 centimeters of needle in if you suddenly something gives. So gentle controlled pressure. And obviously this hand can then move around and introduce the wire. But if you need help introducing the wire, it's acceptable to ask the person helping you with the procedure to introduce the wire. It's not difficult to do that, particularly with two hands. What's difficult is to stop this needle from drifting in or out. And that's what you need to most be concentrating on when you're doing the procedure. So thinking again, I just said sometimes you have to advance the needle further than you think. Well, imagine we're trying to spear this pericardial sac. The problem is that it's quite tough tissue. And so very often, as you press, you'll just indent the pericardial sac rather than actually penetrate it. And if you're going straight at the heart, you can even press the pericardial sac right up against the ventricle, which means that you'll slip straight into the right ventricle, or the left atrium or left, whichever bit of the heart you're approaching. You go straight into the heart when you actually finally start to aspirate something. Now, if that's happened, as soon as you're through, the pericardium will ping back and all you need to do is withdraw slightly and you'll be in the right place. So if you suddenly realize you're in the heart, don't yelp and jerk the needle out of the patient. Just pull it back gradually, a centimeter or so, until you're confident that you're in the pericardial sac. And this means that you do just have to be very careful with the way you're doing it, and be aware that if you're going straight at the heart like this, there is a danger that you go straight through. What is better, if you can do it, perhaps apically in this case, is to go in such a way that you're not going to directly hit the heart if you keep on going. It's a luxury to be able to do this. Bear in mind that the pericardium will still indent, although it'll indent in a slightly different way this time. But if you then go through, the heart, the pericardium will ping back just as it did before, but here you're nice and safe and away from the heart by approaching it like this. And bear in mind, if you're going parasternally, you have no option to do this. You have to be incredibly controlled in your depth, and you've really got no option. And I think if you're going parasternally, it's a tough call whether you go for a Kimmel needle, which is shorter and easier to control over a short distance, but you'll have to stick that Kimmel needle in quite a bit further in order to advance the wire. So there's swings and roundabouts to switching between different types of needle. I would, generally speaking, urge you to use a proper pericardiocentesis needle, which has been designed for the purpose you're using it for. So coming back to the subcostal technique, we want to introduce the needle as the echocardiogram indicated, using the angle that the echocardiogram indicated. Now this is, if you don't have echo, you're aiming at the midclavicular line to start off with, and then you're gradually going more medial, change your angle by about 10-15 degrees every pass. But if you've got an echo to guide it, and remember, an echo not trying to make the pictures look as pretty as they can, but trying to replicate the exact track the needle is going to take, such that you don't damage the liver or another organ. And then you're slowly advancing the needle. You can start off at a relatively steep angle to get under the ribs, under the cartilage cage, but then lower it down to a 30-degree angle and advance it slowly while aspirating. If you don't succeed, if you don't hit oil at an appropriate depth, then take the needle out, re-echo, choose a slightly different track. It's not good to hit the liver. There's a major risk of hemorrhage if you do so, but if there's no alternative, it is acceptable to go through part of the liver. Can you see here the deliberate mistake that whoever's drawn this diagram has shown? They've put the crocodile clip round the plastic bit of the needle. Well, maybe they'd say this is an old style metal syringe, who knows? But the crocodile clip obviously needs to go on the needle. So looking at the anatomy again in a slightly different way, this is a diagram of the sternum, xiphisternum, the pericardial sac, the heart. So our needle is trying to go in at a 30-degree angle to get into this pericardial space and avoid the liver and get under the xiphisternum or under the sternal border. If we look at that slightly differently in a CT scan, can you again see the liver and where it is? And think, if you put that pericardiocentesis needle in steeply, which I would recommend to get under the xiphisternum, you don't have much room to play with before that needle knife tip is scratching that liver in a way that is not going to be good for the patient or for your career. So if you're going to change the track of the needle, it needs to be done as superficially as possible. So the moment you think you've gone deep enough to get under the rib cage, you then need to straighten out or lower the angle to your 30-degree angle and aim towards the heart, and thereby avoid transecting the liver. Now your echo, typically you will be echoing at more like a 45-degree angle, and this is why I keep on saying the echo probe is the needle. Don't worry about the prettiest pictures. Get your shallow angle that tells you the specific details that you need to know. If we're going subcostally, imagine this similar sort of heart situation. and we're going at a 30-degree angle, we have this sort of an error margin. We have maybe 2 or 3 centimeters that the needle can penetrate between the pericardium and the heart. If we're going at a steeper 45-degree angle, not only may we go through the liver, but we've also got less depth error margin. If we could go even more shallowly, that would be even better. We'd have as much error margin as we liked. Obviously, you need to know from the echo that there's not zero sort of subcostal, or there's the higher parasternal separation, because maybe there's no fluid here, and actually you're going to risk hitting the left anterior descending artery. But in the vast majority of situations, if you choose a more shallow angle, there isn't that much to damage between the pericardium and the sternum, and so you can actually go in deeply and not have to worry too much about it, and have loads of echo separation where you implant, where you penetrate with the needle. So long as you're going very superficially, you can afford to potentially go in more deeply. And if I just come back, one other point I wanted to make with this image is this distance here, if you're going at your 30-degree angle, will tend to be longer than the length of your Kimmel needle. So unless you've got somebody who's very slim indeed, or very small, it's likely to be about 10 centimeters that you have to go in with your needle to penetrate the pericardium if you're going subcostally and you're avoiding transecting the liver. Moving on to the parasternal technique. If you're going parasternally, you want to insert the needle perpendicular to the skin. So you're going straight down. You want to go over the cephalad border of the rib, of the 5th or 6th rib, and that just means the top border, because that way you're less likely to damage the neurovascular bundles. And you want to go right up against the sternal margin, and certainly within a centimeter of the sternal margin, to prevent injury to the internal mammary artery. Now, you can also go a right parasternal approach. Why would you ever want to? Well, Alice suggested that to me once a while ago, and I'll show you an example of why that might be necessary in just a second. So just bear in mind that when we're doing an apical or a parasternal, this is the sort of bit that is the dragon's bit. So do not go between 1 centimeter out and 6 centimeters out from the sternal margin. So this is the sort of case that I did with Alice about 5 or 6 years ago. It must have been Alice, wasn't it? Where there was a big pericardial effusion, but not so easy to get at. We might have been able to go apically, but here there was a beautiful echo separation done parasternally, but from the right-hand side. So sometimes that can work. Don't rule it out, but it obviously wouldn't be your expected approach. If you're going apically, you need to be 5 centimeters lateral to the parasternal position, or 6 centimeters from the sternal border. You obviously kind of got flexibility in the space that you choose. Again, you're going over the top border of the rib, but you must have a good apical echo window, because if you can't see the heart, it's because the lung's in the way, and so you should be expecting to cause a pneumothorax. These are the pros and cons of the different approaches. Subcostally, it's familiar. You've got a wide angle of approach options, and usually one of those angles is going to be viable. If you don't have access to echo because it is such an emergency, you can't do anything else, I'd need you to justify that very strongly to me afterwards at the post-mortem. But if there's no echo option, this is going to be your preferred approach. The cons are that the liver is very often in the way and needs to be carefully avoided. It's often pretty deep. I'd say very often you have to go in 10 centimeters to get there if you're going in an appropriately shallow angle. And particularly in obese patients, it can be really rather challenging. Apical, on the other hand, its advantage is that it's usually quite shallow, and I would say an apical is probably my favorite approach if it's a viable option, because it's usually fairly shallow, and because you're also going up against the thick-walled LV, which is much more tolerant to being punctured. If you put a needle through the LV and pull back, you're likely that it will seal the hole that you've made. And you've also got to go in a lot further. You've got much more opportunity to realize you're in the wrong place before you actually get into the heart. And And the coronary arteries are small at the apex. The chance of damaging a coronary artery is much lower. But on the other hand, patient's habitus could make it quite challenging. There's a risk of pneumothorax, and the intercostal vessels, you need to be careful to avoid those if you can, going over the upper border of the rib. Parasternal, on the other hand, that has the pro that it has the shallowest approach. So usually it's a very superficial puncture that you need to do, but there are lots of concerns with the LAD and internal mammary artery there. So I would advise against parasternal if you have an alternative option. So how do we confirm that we're in the right place to do our pericardiocentesis? This is one of the most critical bits. Once you've got the needle in, if you dilate up the tract with the drain and you're in the heart, then you are in a world of hurt. Whereas if you you recognize you're in the wrong space with the needle and pull back, even the right ventricle or even the atrium, you'll be unlucky that that hole doesn't close fairly promptly, and you'd be unlucky if it caused any problems. So knowing where your needle tip is essential. First thing to do when you've got the needle in place is to aspirate about 40 mils. That should be enough to relieve tamponade physiology, and it gives you some fluid that you can squirt into a pot and look to see, does it clot? Because if you've aspirated blood from the right ventricle, it will clot. Also, you can assess the color. If it's straw-colored fluid, then hopefully it is pericardial. It might possibly be pleural, so don't fall into that trap. But aspirate 40 mils, no more and probably no less. If the patient is in tamponade and you're aspirating blood from the right ventricle, then you expect the patient's blood pressure to suddenly drop, or you don't really notice their blood pressure dropping so much as them becoming unresponsive, because the heart's struggling as it is, and you've suddenly taken away the pressure in the right ventricle, and it takes a minute or 30 seconds or so for that blood to circulate back into the right ventricle and the patient to recover. But they will not like it if you aspirate from the right ventricle when they're in tamponade. I know because I've done it. So aspirate to relieve the tamponade physiology, maybe see the blood pressure come up, and to assess the fluid. Use ECG monitoring. I hope that you're all familiar with this. If you're not, then you must become familiar with it, because I would rate ECG monitoring as probably, along with radiographic assessment, the most useful tool for telling you that you're in the right space. I'll show you what that looks like in a second. Radiographically, you want to store images of the wire and later the drain in place, but you also want to see that the wire is in the pericardium and could be nowhere else. And the further you can advance the wire, the better. Don't want to force it. If you're meeting resistance, that would be a sign you may not be pericardial, actually, if you're meeting resistance. But what you want to do is make it curl around the pericardium so that you can say unequivocally that that could not be in the heart. We can use echo, both directly visualizing the needle tip. I once did a pericardiocentesis on ITU at the Royal, a horrible procedure with a very tough pericardium. I needed the obturator to get in there. I obviously didn't have any fluoroscopic or ECG guidance. I was dependent on echo, but the anaesthetists, they do their central lines with echo guidance all the time, and actually were able to show me the needle tip as I advanced it, so I could actually see it penetrating the pericardium. So actually, once they helped me with the echo direct guidance, it was fine. And use of echo bubble contrast can be very helpful in this circumstance, because you want to be absolutely confident that you're in the right place. You could use hemodynamic monitoring, as we've just said about removing the 40 mils. That can help you a bit. You could even put a transducer on it, but I would say that's a sort of a small print and probably not something I'd hang my hat on. So what do I mean by ECG guidance? This is from a pacemaker implant, and when we're putting in pacemakers, we want to know that our screw on our pacemaker lead is in the heart muscle, and so we look for ST elevation. This is exactly what you do not want to see when you're doing a pericardiocentesis. You want this blue thing to look like the green thing here. You want it to tell you or show you a body surface ECG. That tells you that you're not in the heart. So if you're advancing apically and you start to touch the left ventricle, before you penetrate it, you will see stonking ST elevation telling you that you're in the wrong place. If it's the right ventricle, it's such a thin wall that you'll probably be through it before you know what's happening. But as you aspirate blood, you will also see the ST elevation, and you can simply slowly withdraw the needle until the ST elevation goes away, and then you know you're in the right place. So ECG is incredibly helpful for monitoring where your needle tip is, and I would urge you to use it and to be aware of how to use it. It's very easy to do it. You just attach a croc clip to the pericardiocentesis needle and pass the other end to the cardiac technician and ask them to set it up as they would for an endocardial lead. The blue croc clips that come in the pericardiocentesis pack are not long enough, so get a red and black one. They'll be able to find those for you easily in the lab to do this. What about X-ray? So here we have a wire. Can you see that that couldn't possibly be vascular? But actually it couldn't possibly be pericardial either. So that's what it looks like if you've stuck it into the thorax, into the lung cavity. So it's wrapping around the lung rather nicely there. So this means you need to withdraw and try again. And this is what we're looking for, wrapping around the heart. There is absolutely no way that this is inside a ventricle or anywhere else. This must be pericardial. So we can be very confident there. If we using echo, you can visualize a needle puncturing the pericardial space. Alternatively, you can inject bubble contrast. Don't try and make the bubble contrast yourself. That's what your help is there for. Bubble contrast is very hard to make with saline or with sometimes people take a little bit of blood and saline and try and do it with that, which is better. But I'd suggest use a bit of colloid, some Volplex, and that makes beautiful bubbles if you're trying to use echo contrast as your main way of working out if you're in the right place. So what about some tricks in difficult circumstances and other things to be aware of? I apologize. I think I'm probably running over, and if you need to leave the meeting, please feel free to do so. As I say, we're recording this and we'll post it online so you can catch the end. If you can't penetrate the pericardium, use the obturator. That will allow you. You won't be able to aspirate, which is quite scary, but you'll be able to use the ECG to see if you're in the wrong place. And you know from your echo image how deep the needle needs to go. You can just use the obturator to advance 0.5 centimeter and then take the obturator out. That's fine. But that allows you to get through a tough pericardium. If the wire is definitely pericardial, but it's not advancing, or if it's kinked, then you could use a 6 French dilator. That will allow you to reposition the wire or take a fresh wire. Now, you should know that you're in the right spot before you do this. You do not want to dilate into the right ventricle. But by doing this, you can advance the wire deeply in, and the further in you get that wire, the easier it will be to get your drain in. The last thing you want to be doing is worrying about the wire flicking out of place as you push the drain in. So if it's advanced, it's definitely pericardial, but then you start to lose position. Take out the drain, you put in a 6 French dilator, and then reposition the wire. It's really important to keep the wire taut so it acts as a railroad to get the drain in. And if you keep it taut, it won't kink. But if you are not keeping a tight hold of it, and it can be scary to pull on the wire, you can worry you're going to pull it out. So the tendency is to let it advance. But if you do that and it kinks, it will be much harder to deal with that kink. So keep the wire gently taut, not pulling on it, but not letting it advance as you're pressing in the drain. If you can't advance the drain, then dilate the track. And the pacing, we use lots of different split sheaths at different sizes. You can put in a 6, 7, 8, 9. Start small with a 6, but I'd probably then go up to an 8 and then potentially to a 9. Don't use the split sheath bit of it, just use the dilator part of it. And if that's not working, the other thing you could do is use something like an Amplatzer super stiff wire from the TAVI team's equipment, that will give you a much stiffer wire that you can advance. Don't try and advance that wire through the needle, through the pericardiocentesis needle. You should change to a dilator first. So having inserted the drain, what do you do next? Well, first off, drain to dryness using a 50 ml syringe. Record the amount that you drain. Bear in mind you won't get it all out, but try and get most of it out. And while you're doing that, monitor the hemodynamics and repeat the echo to see that the fluid is clearing. And that's the point at which you can start to relax, when the patient's blood pressure comes up and the echo shows the fluid is clearing. Secure the drain. Different people use different techniques. I don't tend to stitch it. I just use dressings. I won't try and explain that now in the interests of time, but suture it, do whatever your consultant wants. Expect the patient to complain of pleuritic pain. As soon as you cleared the lubricating fluid, that drain is going to rub against their pericardium and cause pain, often felt in the shoulder, left shoulder, and often pleuritic. So offer them morphine for that. And document the procedure clearly in the notes. You want a full description of you did the echo, how you approached it, etc., but put in how many passes you'd made and put in if you've got any complications, and send the sample for appropriate investigations. And this would be a reasonably standard set of investigations to do. Once the patient's back on the ward, speak to the patient and the relatives. Record the output that you've had from the drain, and once you think you've drained all that was there originally, empty the bag. That means that you don't need to worry about are they keeping track or not of how much fluid is coming out, because you know the bag was empty, and therefore any reaccumulation is any further drainage is reaccumulation. That's a really useful thing to do, and that's something that you can do. I usually have gone home at this point, but when you're on your night shift, just get them to empty the bag once you think you've drained all that's going to drain immediately out of it. We want to know how much came out, but then we need to know about the rate of reaccumulation. If you do that, then you shouldn't need to spigot it. You only spigot it if you're not sure how much is coming out. It increases the risk of infection if you do that. And do expect to get that drain out within 24 hours, because it's not pleasant having it in. There's no advantage to keeping it any longer. It will either become very obvious within the first 12 hours that a lot of fluid is still coming out, it's reaccumulating fast and you can't take it out early, or else it's going to be very obvious that very little has come out, having drained the main part of the fluid, and you can now safely remove it. Bear in mind, if it's still lots of blood is coming out, they may well need surgical closure. That's usually obvious fairly straight away. And get a chest x-ray to confirm location. I've nearly done. A few special circumstances. Acute procedural tamponade, just bear in mind how stressful that is. Ask for help. Everything you're doing is preparation. Every time you do a pericardiocentesis, you're rehearsing for this really stressful, really challenging event that will probably only come around about once every 10 years. So be ready for it when it does, because you've rehearsed this mentally many times in advance, and because every time you do a pericardiocentesis, you do every part of it as well as you can do it, rather than just trying to get one done as simply as possible. Lima graphs can give people worry about hitting something unpleasant. I'll come back to that in a second. Recurrent pericardial effusions can be loculated. That's something else to think about with your echo. We might need to do a pericardial fenestration. You don't want to leave the drain too long, so if the person who does the pericardial fenestrations isn't around, maybe we need to delay before we do the pericardiocentesis if we can. I may have something to say about the approach we take. Think in young patients about acute lymphoblastic leukemia. It's a rare condition, but it can be life-threatening within a few days, and they need a fresh sample of pericardial fluid to make the diagnosis, which is very often the way it's diagnosed if they come through us. So if you've got a young patient with a large pericardial effusion, feel for lymph nodes and think acute lymphoblastic leukemia. The pericardial effusion might be the least of their concerns, but by draining it, you can make the diagnosis, but only if you send off a fresh sample of fluid. Aortic dissection. and myocardial rupture are obviously special circumstances where maybe trying to drain the fluid isn't the first priority so much as getting emergency surgery, and anything else is just temporizing as best you can. Special circumstances cabbage, you might be worried that you're going to damage the internal mammary artery, but your friend are the clips that the surgeons put on, and you can see how close to the sternal border the internal mammary artery is in this. This is one of my patients. Um, so you probably could go parasternally just as normal within a centimetre, but you can see how close to the sternum it is. I'm always more comfortable if I take an apical or subcostal approach, unless I don't have the other option. So, in summary, rehearse the procedure mentally before performing. Go through it in your head before you actually approach the patient, while you've got the privacy and you don't have lots of people looking at you expectantly, unless it's an emergency. And treat every pericardiocentesis as you do as practice for the big one. Don't just say, oh, I've got a subcostal window, I can do that in my sleep, I can put the wire in, see that it's pericardial and not worry about anything else. Put the ECG on. Think about using some bubble contrast. Think about every part of what you're doing so that when you're doing a true emergency, you'll be ready for it. If you're causing that emergency, if you get tamponade as part of a procedure you're doing, ask for help. Don't try and do it yourself, because it's really stressful. It's really difficult knowing you caused that to deal with it. You don't want that extra layer of stress. Ask for help. Don't be too proud to do that. And ask for help generally in pericardiocentesis. Don't try and be 20 pairs of hands. Your two hands are concentrating on getting that needle into the pericardial sac and not moving from that point, not losing the position, not advancing and touching the heart. Think of the echo probe as your needle. That echo probe needs to form the exact track that your needle is going to take so that you know what structures you're going to hit. You're not just echoing to say that this is the window that I'm going to take. You're echoing to say this is the exact angle, depth, the safety margin that my needle is going to transect in getting to the pericardial space. If you can optimize the patient and your environment first, it's always better to go in with everything, all the planets aligned. Trying to do something in a rush when everything is suboptimal is likely to lead to failure. And if that leads to delay, it can make the situation worse, not better. Take your time if you have it. And once you start the procedure, that left hand stays on the patient and is not removed from the patient until you have a wire in the pericardial sac, and therefore it's safe to let go altogether. Thank you very much for listening. Are there any questions? So I'm very happy to field any questions afterward. I'm sure you've got afternoon sessions to get off to. I've sent you round a summary of the what to expect tomorrow during the simulation day. So please just run through that. It'll tell you what we're assessing, when we're assessing it. Please request your DOPS from either myself or Dr. Banning, depending upon which side of the carousel you're on. Do that before Thursday so that we can do it on the day. And I look forward to seeing you all there.